this puts us in a good position to start talking about gastroenterology. I'm probably not going to get to any specific disorders today, and we'll just focus on the fundamental anatomy and physiology of the gastrointestinal system. The gastrointestinal system, or the gastrointestinal tract, is also or often referred to as the alimentary canal. And this is an interesting concept because the GI tract, if you think about it, is basically a tube that goes through your body, starts at your mouth, and ends at your anus. And guess what? It is a tube that is completely separated from the internal environment of your body. And in fact, if that tube were to become compromised in some way, what would happen? The contents of that tube would spill out uncontrollably into our body, and would most certainly be a very disastrous situation, lead to lots of inflammation, infection, and so on and so forth. So some people look at the gastrointestinal system as it being an outside environment that's inside of the body, if that makes any sense. Because what's going on inside of the GI tract is so completely different from what's going on inside of the rest of the body. So it's kind of an interesting concept that you have the outside world inside of your body kind of walled off. So let's go ahead and just talk about the GI tract, and we'll start in the upper airway, or the upper GI tract rather, and we will work our way down. Let's see. Okay, so it starts here, the mouth. All right, and we have some specialized anatomy in the mouth or the oral cavity. Obviously, we have teeth, and what's the role of teeth? What do they do? Mastication, so chewing, right? So they chew food up, they tear it up, okay? And they kind of pound it and pulverize it, and they turn the food into much smaller chunks, right? And ultimately what happens is, as we chew the food, okay, that food gets turned into what's known as a bolus, right? Gets turned into a soft bolus that can fit into the esophagus and be brought down into the stomach. And some other things that are going on are you have what are called salivary glands. You have 3 of them, one set of 3 on each side, the right and the left side. So you have what's known as the sublingual gland, salivary gland, which is right underneath the tongue. You have the submandibular salivary gland, which is right underneath the mandible here. And then you have what's called your parotid salivary gland, which is kind of lateral up in here. If you guys see where I'm pointing to on myself here. Right? And you have these on each side of your mouth. And what do salivary glands do? Well, they secrete saliva, right? And what is the role or the function of saliva? Well, it is to moisten the food, right? You want that bolus to be moistened so it will travel down your esophagus easier, okay? It's good at clearing the mouth, okay? When you have little bits of food or debris and stuff, it's good at cleaning and clearing that stuff out, okay? It also aids in taste, okay? We cannot taste normally without having adequate amounts of saliva in our mouth. And then, quite importantly, saliva also contains an enzyme called amylase, or salivary amylase. And as we've talked about, what is the role of amylase? Good. So it breaks down polysaccharides, right, to monosaccharides. So you have digestion of carbohydrates beginning in the mouth. Proteins and fats are not typically, their digestion does not typically begin in the mouth, in the oral cavity. Okay, good. Then you have the tongue. What's the major role of the tongue? Taste and swallowing. Good. And then I didn't draw it in here, but you also have your uvula, which is important because it kind of helps angle the bolus as a bolus passes from the oral pharynx into the laryngeal pharynx. And then you have a valve, right? You have your epiglottis that needs to close to cover the trachea, and then that bolus of food can pass down into the esophagus, all right? And the esophagus connects the laryngeal pharynx to the stomach here. And the esophagus is a thin muscular tube. And when we talk about the GI tract as a whole, what kind of motion do those muscles undergo to move the bolus? Peristalsis, right? And peristalsis is a wave-like motion. Just think of that as being a wave-like motion. You guys okay with that? All right. Swallowing is sometimes referred to as deglutination. Okay, so if you see that word, deglutination, it just means swallowing. All right. So we've chewed that food up. We've begun to digest some of the carbohydrates. We've lubricated that food, turned it into a bolus. We've swallowed it. It now travels down the esophagus and into what structure? What's this here? Into the stomach, right? And the stomach sits right underneath the diaphragm, right? And the stomach has, when you look at it, it has some different components to it. You have this upper curve here called the fundus, and then it drops down where the esophagus connects, and you have a little depression called the cardiac notch. Why is that called the cardiac notch? Well, because your heart sits right up here, superior and left to that, right? And then you, of course, you have your diaphragm comes down as well. And then you have, the stomach is not symmetrical, but is rather asymmetrical. So you have this outer curve, this curve that pushes out here, and this is known as the greater curvature. And then you have this curve that curves inward here on the right. This is called the lesser curvature. You guys okay with that? And then the very top part is called the fundus. And then this whole part here is known as the body of the stomach. So far, so good? All right. The stomach is a muscular organ, like most organs of the GI tract, okay, or of the canal at least, are muscular. There are 3 layers of muscle. You have these longitudinal muscles on the outside, okay? And then in the middle, you have these circular muscle tissue. And then the inner is a muscle tissue at an angle, or what we call oblique. And you have your 3 layers. Then you have inside, you have all these little folds on the inside of your stomach. And these folds make up what's known as the gastric mucosa. And we'll look at the gastric mucosa in some detail here in just a little bit. You also have valves called sphincters. And a sphincter is just a circular structure of muscle tissue, of smooth muscle, that can kind of close off, can open and close. And so you have a sphincter here called the lower esophageal sphincter, right here where the esophagus comes into the stomach. And then you have another sphincter here called the pyloric sphincter, where the stomach transitions into the small intestines. And this area of the stomach is known as the pylorus, right? And this is a relatively common area for the development of ulcers, right? Or what we call pyloric ulcers. And you guys may have heard the term PUD. Has anyone heard that? PUD? That stands for peptic ulcer disease. Peptic means stomach, right? And ulcers tend to be in areas of the body that are areas of the GI tract that are most acidic. So either the stomach or the first part of the small intestine, known as the duodenum. So you can get duodenal ulcers as well. So peptic and duodenal ulcers tend to be the most common areas where you get ulcers. Okay, You guys okay so far? So that bolus of food makes its way into the stomach, and what's going on in the stomach? What's going on there? So yeah, we have further digestion. So if you look at the stomach, first of all, the stomach is covered in mucus. The inner lining of the stomach is covered in a thick mucus layer. And why do you suppose that is?
Because of pH.
To protect it from acid, specifically hydrochloric acid. Okay? Why is there hydrochloric acid in your stomach? That helps break down the food, and hydrochloric acid has another very important role that we'll talk about here in just a couple minutes. Okay? You also have other hormones being secreted in the stomach. You have something called pepsinogen, and you have something called gastrin. Okay, these are hormones. Remember when I said I'd come back to the stomach, the GI tract, and talk about hormones, because they play a very important role in the GI tract. You guys good with that so far? Cool. All right, so what I'm going to do is I'm going to take a section of the stomach here, and I'm going to enlarge it right here. So this is what I've done. This is actually microscopic, and we've enlarged it. Okay, so I have the basal layer here. Okay, so this would be toward the outer part. And then I have my inner layer, we call the apical layer. So this would be the inner lumen of the stomach. This would be the layer of mucus on top of that. And then we're looking at the mucosa here. And as you notice, the mucosa is lined in several different cell types, and I've kind of color-coded them. So these yellow cells here are the mucus cells that secrete the mucus blanket that protects this whole thing. Okay. You also have these reddish cells here. Do you guys see those there, those reddish cells? These are known as chief cells. And these are the cells that secrete the hydrochloric acid. And then embedded in this layer, you have two other types of cells as well. You have these grayish looking cells here. Okay? And these are known as parietal cells. And what the parietal cells do is they secrete a prohormone called pepsinogen, or a proenzyme rather called pepsinogen. Okay, and here's a cool thing. So pepsinogen gets released, but it is in its inactive form until it comes into contact with hydrochloric acid, and then hydrochloric acid converts pepsinogen into pepsin. And pepsin is an enzyme that helps break down proteins. So this is kind of an ingenious mechanism that you have here, is you have this pepsinogen that is inactive, and it can only be activated in the presence of hydrochloric acid. Does that make sense?
And it's not the molecule necessarily, right? It's the pH level that changes it, or is it hydrochloric acid?
Yeah. It's a pH. Okay. Yeah, that low pH. Yeah, that converts the pepsinogen into pepsin in its active form. Right? You guys okay with that? So just like you have in your blood, you have angiotensinogen in your blood. And that angiotensinogen then gets converted to angiotensin when renin gets released from your kidneys. So you have all this inactive stuff floating around, and then it gets activated by something else. That's what's happening here in the stomach. Are you guys okay with that? Okay. So I think the next question is, well, what causes these chief cells to secrete hydrochloric acid, right? Because it's hydrochloric acid that kind of kicks the whole thing off. Well, there are two things, primarily, okay? There is histamine, first of all. Histamine is a very important part. And when histamine gets released, that can act upon the chief cells, okay? You guys okay with that? And you also have something called somatostatin. You also have these G cells. These are dark blue. Do you guys see that there? These G cells release a hormone called gastrin. You guys see that there? Gastrin. And these G cells release the gastrin, and then the gastrin acts upon the chief cells and causes them to release hydrochloric acid, which then activates pepsinogen into pepsin. Boy, doesn't that sound as convoluted as the endocrine system yesterday? Kind of turtles all the way down. So, just to kind of review, you have histamine that gets released, and you have these G cells that release gastrin. The gastrin then acts upon the chief cells, causes them to release hydrochloric acid, and then that hydrochloric acid can go on to activate pepsinogen and convert it into its active form pepsin, and the pepsinogen is released by the parietal cells here. And then you have the mucus cells releasing mucus the whole time. You guys okay with that? All right. So the major thing you have here in the stomach is you have this pepsin that helps digest proteins, and you have the hydrochloric acid, which aids in the breakdown of foods as well. Cool with that? Kind of makes sense? Now, I just want to take a quick diversion here, though, and there are some medications that work at the level of these cells, okay? And the first class of medications I want to talk about are something known as the PPIs, or the proton pump inhibitors. And the proton pump inhibitors inhibit proton pumps in these chief cells. And basically the way these proton pumps work is they pump and they create a gradient of hydrogen ions, and those hydrogen ions are used to make the hydrochloric acid. You have hydrogen ions and chloride ions to make hydrochloric acid. Does that kind of make sense? And so these proton pump inhibitors inhibit those proton pumps and inhibit the ability for these chief cells to concentrate and create hydrochloric acid. And these proton pump inhibitors tend to end with the term zol. So lansoprazole and pantoprazole are two types of proton pump inhibitors. I believe they go by the names Protonics is one of the trade name, which I believe is pantoprazole. I think pantoprazole is Protonics. And then there's lansoprazole, and I forget what the trade name, or what a common trade name for lansoprazole is. But there you have it. Nexium. I believe it's Nexium. Esomeprazole is, which is another protozoa. I forget, I'm not sure what lansoprazole is. Yeah, Prilosec, yeah. So those are all proton PPIs, proton pump inhibitors. Now, we also have medications that work over here. Remember I said histamine release? And there's yet another cell type that I haven't illustrated here. And this other cell type, these are known as the Ecl cells, or the enterochromaffin-like cells. That's why we call them Ecl, because it's a little easier to say. And these cells release histamine, which also acts upon the chief cells. And so guess what? Histamine blocking drugs can also decrease acid levels in the stomach. Specifically, histamine 2 blockers. You have two different types. You have H1 and H2. And the histamine 1 is kind of the histamine that we associate with allergies and anaphylaxis and what comes out of the mast cells, and they degranulate and all that. And then you have H2, which is more important when it comes to gastric acid secretion. So guess what? You can also administer H2 blockers. Probably the most common H2 blocker is ranitidine or Zantac. Okay? Ranitidine or Zantac. All of these PPIs and these H2 blockers, for the most part, can be given orally, or they can be given intravenously. And these are commonly administered in patients that have, if you suspect them of having an ulcer or possibly a GI bleed and we want to decrease acid levels, or if they have some other problem like something known as a hiatal hernia. What's a hiatal hernia? Yeah, so this area here, the hiatus kind of herniates up into the thoracic cavity, right? And that can cause lots of heartburn, or what we call regurgitation, where stomach contents gets regurgitated back up into the esophagus, and that, of course, is very acidic, and it can burn and damage the lining of the esophagus, right? And that might even lead to ulcerations of the esophagus or long-term changes. Something known as a Barrett's esophagus, which is a precancerous esophagus, and we can go on to develop esophageal cancer, which is a very difficult to treat, very bad form of cancer. You guys okay with that? All right. You may have heard the term GERD, gastroesophageal. So it's gastroesophageal reflux disease. These medications are very common in patients that have GERD, patients that have a history of ulcers, and so on. You guys okay with that? All right. And sometimes we even give them to patients who have GI bleeds. And a very common application for these types of drugs is in hospitalized patients. Why do you suppose that is? That if you get admitted to the hospital, particularly if you're sick, why would we give you these agents? So you go in PO, and also you are under stress. And have you guys ever heard of the term a stress ulcer? Yes. So when people get admitted to the hospital, a standard drug that they go on is a PPI or H2 blocker for stress ulcer prophylaxis, to prevent them from getting stress ulcers. And the sicker they are, the more important this is. Okay? So it may seem like a minor thing, but it certainly is an important part of dealing with someone who's been hospitalized. You guys okay with that? Does that sort of make sense?
They give these a lot to like pregnancy too.
Yeah, because GERD is very common. Yeah, very common in pregnant. Yeah. Not so much the first trimester, because these are teratogenic to some, but second, third trimester. The more pregnant you are, well, that's kind of a stupid thing to say, because you're either pregnant or you're not. But
the bigger you are,
the more gravid you get, the more of an issue this becomes. You putting pressure on the stomach. Yeah, absolutely. Cool. Are you guys okay with that? And remember how we were talking about somatostatin yesterday? Somatostatin not only inhibits the release of insulin and glucagon from the pancreas, but somatostatin also inhibits G cell activity. So there is a drug called sandostatin or octreotide, which is a derivative of somatostatin. And we can give that to patients typically that have GI bleeding, and that can help decrease acid levels as well. Okay. So again, these aren't medications that we have in our scope, although I think, is ranitidine or Zantac? Is that in scope? Or is there, I know there was talk about putting a little paragraph that we can transport these particular. I believe proton pump inhibitors and H2 blockers are transport med. Yes. Excellent. Good. Okay. Yeah. So we do occasionally run into these drugs, and we can transport and monitor and continue the infusion once it's been initiated. So I figured it was important to at least mention them and what their use is. Okay, you guys okay with that? Okay, cool. So once that all occurs, then the contents of the stomach exit through the pyloric sphincter, into the first part of the small intestine called the duodenum. Once that bolus exits the stomach, we no longer call it a bolus, right? It exits as a liquid. It's a watery liquid known as chyme or chyme, depending on how you want to pronounce that, all right? So it is a bolus from here down into the stomach, and then for the rest of its route through the small intestines, it's known as chyme or chyme. You guys okay with that? And the intestines are what, about 20 feet long or thereabouts? And there are three major sections of the small intestines. You have your duodenum, your jejunum, and your ileum. Are you guys okay with that? And now, obviously, this is not to scale or anything like that, and obviously they're very convoluted, but you've got your duodenum, your jejunum, and your ileum, and what primarily occurs in the small intestines?
Absorption of nutrients.
Absorption of nutrients. Okay, so further digestion and further absorption of nutrients occurs in the small intestines. Do we absorb water in the small intestines? No, not much. Not much. Most of the water absorption occurs in the large intestine, so guess what? Whatever's in the small intestine is going to be liquid, right? It's going to be liquid. It's going to be that chyme or that chyme throughout the entire small intestine. And then as you transition to the large intestine, the further you go through the large intestine, the more solid that becomes, and it turns in from chyme or chyme into stool, right? Or a bowel movement. Okay, so at the very end of the small intestines, you have another band of muscle, and you have another valve called the ileocecal valve, where the ileum transitions into the first part of the large intestine called the cecum. You guys okay with that? Now there is a very important structure here at what's known as the ileocecal junction. And what is that important structure? The appendix is there, and we'll talk about that in a little more detail. Okay, you guys okay with that? Let's get you on a break. Okie dokie, so we'll finish up with the basic anatomy and physiology, and then on Monday we'll actually be able to go into assessing the GI system and talking about some of the major disorders. Okay, so now what I want to do is we've talked about what goes on in the mouth, the esophagus, and the stomach. So imagine that food is leaving the stomach and it's in the first part of the small intestine, which is known as the duodenum. Good. So what happens in the duodenum? Well, in the duodenum, there is a tube that connects into the duodenum. Okay? And that tube, if you look at it right here, is known as the common bile duct. So the common bile duct connects to the duodenum. And then as I go up the common bile duct, it bifurcates into two major tubes or ducts. It bifurcates off to the right into what's known as the pancreatic duct. That's here in yellow. And the pancreatic duct goes to the pancreas. So the pancreas secretes substances out of the pancreatic duct into the common bile duct and then into the small intestine there. And if I go to the left, the common bile duct moves up into what's known as the cystic duct and goes into a small sac-like structure that is on the inferior surface of the liver, and that sac-like structure is known as the gallbladder. And then the gallbladder connects to the common hepatic duct. And what is stored in the gallbladder? So bile is manufactured or created in the liver, and then bile moves from the liver into the common hepatic duct, and then it gets stored in the gallbladder. And then the gallbladder contracts and pushes the bile down into the cystic duct, into the common bile duct, and then out of the sphincter here, what's known as the sphincter of Oddi and the ampulla of Vater. That's a little opening and then it gets secreted out in here into the small intestine, into the duodenum. You guys okay with that? So you have bile and pancreatic chemicals getting released into the small intestine. What triggers the gallbladder to secrete, you think? Yeah, you're close. So what happens is as the chyme exits the stomach and enters the small intestine senses that chyme is entering, and it secretes a hormone called cholecytokinin. And the cholecytokinin that gets secreted by the small intestine then stimulates the gallbladder to contract and to secrete bile. So again, that whole turtles all the way down analogy, all this interconnectedness of all these little feedback loops doing this, that, and the other thing. All right, you guys good with that? So what is the role of bile? We talked about this yesterday a little bit, but what is the role of bile? Say it again?
Emulsification of fats.
Perfect. Bile is an amphipathic molecule that emulsifies lipids and allows them to be dissolved in the aqueous or the water-like environment of the small intestines, right? And that ultimately allows enzymes to break fats down into their monomer units, or their fatty acids, which then can get absorbed lower down into the small intestines. You guys cool with that? Some other things happen as well. There are substances that are secreted by the pancreas. The first substance that gets secreted is bicarbonate. Why do you think it's important for the pancreas to secrete bicarbonate? Yeah, I can't get anything past you guys today. Yeah. Because that chyme is very acidic, right? And so we need bicarbonate to neutralize or to buffer that pH, to increase the pH. Because the pH of your stomach is right around 2, right? And so you need to increase that rapidly, or you will damage, right? You will very quickly damage the intestinal mucosa. Other substances that get released by the pancreas are lipases, and what do you think these do? Lipid digestion, good. Amylase, again, is for carbohydrate digestion, and nucleases, which, what do you suppose nucleases do? Break down DNA and RNA, right? So you have all of your, remember we talked about the macromolecules of life in pathophysiology? You have the ability to break down all of those macromolecules into their small monomer units, which then can get absorbed, right? You need smaller molecules to get absorbed into the intestines, and then they get circulated to the liver, where then they are turned back into larger macromolecules that the body needs. Does that kind of make sense there? You have this repurposing mechanism, if you will, kind of going on there. Okay, so as that chyme transitions through the small intestine, okay, the pH gets neutralized, you have fat, carbohydrate, and nucleic acid along with protein breakdown, and then ultimately what do you need to do to those? Once you've broken them down sufficiently and you've dissolved them in the water, the aqueous environment, what needs to happen to those? You need to get them absorbed into your systemic circulation. And most of the absorption occurs on the inner surface of your small intestine. It's known as the intestinal mucosa. And if you look at the intestinal mucosa has all of these little finger-like projections covering the inner lining. And these little fingers are known as villi, or villus if you're talking about one. And why do you suppose you have all these little finger-like invaginations and folds? Increased surface area for absorption. And then if you zoom in on the surface of these villi, you see that the villi are covered in these columnar epithelial cells that have these little brush-like extensions that come out of them to further increase surface area for absorption. And this is known as the brush border. And this is also covered in a layer of mucus. Okay, so you have mucus secreting cells in here as well. And so what happens is as this chyme travels through here and it kind of flows over these villi here, you have enzymes that get secreted, okay, from the epithelial cells called brush border enzymes, and those enzymes facilitate the absorption of those nutrients into these cells, okay, through phagocytosis, pinocytosis, and then just through simple passive diffusion as well in some cases, okay? And then that makes its way to the circulatory system, the venous system of your intestines, what we call the mesenteric circulation. And then that ultimately goes into the portal circulation of the liver. And the very first organ that all these absorbed nutrients go to, other than the intestines, are the liver. And remember, we talked about that being an important part of pharmacology in something known as the first pass effect. Remember talking about that in pharm, right? Okay. All right. You guys cool with that? Okay. And then finally, that chyme makes its way to the end of the small intestine, the ileum, here at the ileocecal junction, right? And then it passes through the ileocecal valve into the large intestine, and your large intestine is divided into three major sections. Your ascending colon, this is on the right or the left? This is the right side. So that chyme dumps into here, it moves up, and then you have your transverse colon, which transverses, moves from right to left, and then your descending colon, which descends down, and this is on the left side, right? And then it makes a sharp turn or curve, and it kind of has an S-like shape here as it moves toward the rectum, and this is known as the sigmoid colon, sigmoid being S-like. And then finally you move into the rectum, and as you move through the large intestine, you have water absorption, and that chyme becomes stool, and it becomes more and more solid as you move through. And so are you guys familiar with the term let's see, what's the word I'm looking for? A colonostomy. Ostomy, rather, excuse me.
Yeah.
Yes, what is that? A colonostomy. Ostomy,
They go in and they put a hole in the colon.
Good, so you resect, you cut a part of the colon away, and then you pull it through the abdominal wall, and you have an opening out the abdominal wall, and you have a stoma, a colonostomy. And in general, is that stool that comes out of the colonostomy solid or liquid? It tends to be, the more you go towards this direction, the more solid it becomes. And if you had something called an ileostomy, that would definitely be liquid stool, right? Because you're dealing with the small intestine, right? So depending on where that stoma is, right, how far along the alimentary canal you are, will determine the character of the stool or the bowel that comes out of that. You guys okay with that? That kind of makes sense. And then you have your rectum here, and you have two bands of muscle. You have your internal anal sphincter and your external anal sphincter. And then as that hardened stool comes in, stretch receptors sense that sends information up to your brain, and then your brain says, hey, you got to go poop, right? And then you get that what? You get that kind of uncomfortable sensation of having to go poop. You guys cool with that? Okay, I want to go back to here real quick. because there are some people that speculate that there are some problems here. People that have disease or pathology of the odorous, not the odor, the sphincter of Oddi, or the ampulla of Vater, this area here, there is some speculation that opioids might cause this to spasm, and that it's possible that in certain diseases, opioids may exacerbate the abdominal pain that the patient is having. Two classic examples are people that have gallbladder disease or have had their gallbladder removed, and that's known as a cholecystectomy, or patients that have had gastric bypass surgery, okay, where you may have some pathology here. The clinical evidence is kind of dodgy. I don't know that you can make any solid conclusions about that, but it's still an interesting thing to know nonetheless. What have you guys been taught about treating abdominal pain with opioids? Why do we not give opioids to abdominal pain? Because it might make it harder to assess the patient. You guys have all been told that? That's BS. Total BS, guys. Do not buy into that story, okay? Don't buy into that. Give pain medicine if people are in lots of pain. Have any of you tried to assess somebody with severe abdominal pain? What are they doing when they're in severe abdominal pain? They're screaming, they're guarding, and they are generally not interested in talking with you, are they? What happens when you control their pain? They settle down and they actually want to talk to you. So guess what? Pain medicine makes it easier to assess your abdominal pain patient, believe it or not. And this whole mask being something life-threatening, look, what do you think is going to happen to a patient with abdominal pain if we think something is going on when they get to the hospital? What's going to happen? They're getting labs, they're getting potentially an ultrasound, and they're getting a CT scan, likely with some contrast to find out what the problem is, right? So guess what? Give them pain medicine if they need it. Don't fall into that, oh, I can't give morphine because it'll make it harder to, while your patient's, screaming in bloody agony, you can't assess them anyway, right? Yeah. So do not be afraid to give pain medicine to patients with abdominal pain if they need it, okay? You guys cool with that? Okay, cool. The other thing that I want to talk about real quickly here is this area here, because appendicitis is such a problem. When we have appendicitis, first of all, what is the role of the appendix?
I think it's ancestral breakdown rocks and birds.
Yeah, who knows? Yeah, there are lots of speculation. There you go. Who knows? There is some very new evidence suggesting that it may actually have some immune role. It may have some immune system role to it. And so it may not be entirely, quote unquote, vestigial. You guys ever heard of that term, vestigial? Vestigial basically means useless, worthless, no real current application. And traditionally we think of the appendix as being kind of a vestigial organ, kind of like, what's a good example of something that's vestigial? Wisdom teeth, right? Those of us that have had wisdom teeth erupt, what if likely we had to do? Had to have those things extracted, huh? Right? And why? Well, we needed them at one point, when we had big old mouths and we were crunching on bones and cracking nuts with our bare teeth and that kind of thing. But now that, we don't do that anymore, the wisdom teeth have become more or less vestigial. So there is some evidence that suggests the appendix may actually have an immune function. It may be kind of like a lymphatic or lymphoid kind of tissue. And we're learning a lot more about the gut than we've ever thought possible, particularly with the gut biome. You guys familiar with that, the biome? The bacteria, we have lots of bacteria inside of our intestines. Most of it is good bacteria. It helps us digest. And we know that when you alter the gut biome, that can alter lots of things of your body. It can cause inflammation. It can make you more prone to illness. It can potentially even affect your weight. There's some really interesting research that was just published on rats where they took the gut biome from a obese rat and put it into a skinny rat, and what happened? The skinny rat got fat. So, and then vice versa. So there is a very strong connection with what's going on inside of your gut. A lot of stuff going on. In fact, what's going on in your intestines is so important that there is actually nervous tissue dedicated for the gut that is not directly connected to the brain. This is gut-associated nervous tissue. And there's gut-associated lymphatic tissue, what we call GALT. But it kind of has its own immune system that isn't necessarily directly connected to the rest. So there's a lot of autonomous stuff going on there, and a lot of important stuff going on. And we found a devastating disease, something known as C. diff. You guys familiar with that? Clostridium difficile. It's essentially life-threatening diarrhea. It's a drug-resistant. What's that? Well, it's a drug-resistant bacteria, hard to get rid of. Guess what? What is the most effective therapy for that now?
Give me someone else's transplant.
A fecal transplant, where we actually do an endoscopy, put a camera down, and suck out some of the biome from somebody who's healthy, and then inject that into the person that has C. diff. And the cure rates of C. diff are astronomically high based on this. It is now a fully recognized medical therapy. It's known as a fecal transplant for treating C. diff, right? Mind-blowing, huh?
Disgusting.
It's a little odd to think about, but yeah, it is, yeah. So a lot of stuff going on there. So anyway, going back to the appendix here, where, if you have inflammation of the appendix, where does that pain tend to present?
Burns point.
Yeah, what quadrant?
Right.
The right lower quadrant. And there is this classic area called McBurney's Point. And where is McBurney's Point? Yeah, so, find the superior spine of your iliac crest. Okay? So the top of your iliac crest. Find your belly button, your umbilicus. And then that distance between the spine and the umbilicus, cut it into 3 sections. And a third of the way to the umbilicus is McBurney's Point. And that is the anatomical location of the appendix in most people that have normal anatomy. That's called McBurney's Point. And so tenderness in that area, McBurney's Point tenderness, is a classic finding associated with appendicitis. And as we're going to learn next week, though, the differential diagnosis of abdominal pain is tough. Yeah, so and you can, what you can do is sometimes if you smack the foot, that force gets transmitted into the peritoneum, the irritated peritoneum, that can cause pain. Or sometimes what we'll do is, like if a kid has abdominal pain, one of the things we can do is have a kid jump. Hey, can you jump for me? Jump on your feet. And if they jump on their feet, then that might not be as worrisome as the kid who's like, oh, okay. But again, that's really unreliable kinds of findings. And as we're going to find out, the assessment is really tough for abdominal pain in particular. You could have an ovarian cyst, or you could have an ectopic pregnancy that could present exactly like appendicitis. You could have a gallbladder attack that presents like heartburn. You could have a STEMI that presents like a gallbladder attack or heartburn. So it's a really tough diagnosis. So in general, when it comes to, even though we'll talk about it in detail today, when it comes to assessing and treating somebody with some sort of GI complaint, guess what? Get them on the monitor, get a 12-lead on anybody with abdominal pain. Basically, if they have pain or problems in their body other than their limbs, you need to get a 12-lead on them. It's just, and even then you can have referred pain into their limbs. So yeah, in general, man, if you have somebody with a medical complaint, it's a pretty good idea just to get a 12-lead on. Just doesn't really matter how it. Yeah. Okay. So we've talked about most of the major players of the alimentary canal and some of the other organs, like the liver and the pancreas, and we'll talk about dysfunction of these organs and some of the more common problems on Monday. So I think I'm going to cut it off there, and we'll just take a couple minutes, and we'll come back and just recap what we've covered so far this week and make sure we're all doing all right.